Good morning. This is Andy Shore from Washington, D.C. with a quick literature review of what's going on in pulmonary and critical care medicine. Two articles I want to share with you with this iteration of our dialogue. The first is by Levy and colleagues in the early June issue of the Annals of Internal Medicine. In this article, the authors focused on the impact of critical care physician management on outcomes for patients in intensive care units. Their goal was to try to identify the impact of ICU structure and the use of full-time intensivists on outcomes for patients in ICUs. This has been a very controversial topic, as a number of organizations such as the Leapfrog Initiative, the Society of Critical Care Medicine, and other groups have really focused on expanding access to full-time intensivists as a way to improve outcomes. What these authors did was use something called the Project Impact Database, which is a data set that's voluntary to which hospitals can contribute data about critically ill patients, and actually focused on what was going on with those patients in terms of outcomes. What they did was they used hospital mortality as their primary endpoint, and they did their best to adjust for all sorts of differences in terms of severity of illness, and they looked and tried to compare patients who were likely to be managed by an intensivist versus those that weren't managed by an intensivist in terms of outcomes. What these authors saw was that patients who were managed by an intensivist had worse outcomes, and that mortality risk in terms of being managed by an intensivist remained present even after doing the best they could to control for a number of confounders. Now, one of the strengths of the data set is that it includes outcomes on 100,000 plus critically ill patients. The problem with the data here, and I think it's important to understand the substantial limitations with this manuscript, is that they can't really tell you who's managed by a full-time intensivist. These authors grouped patients into three categories: very little exposure to ICU physicians in the hospital, so say less than 5% of patients managed by that, then somewhere between up to 95% of patients managed by an intensivist in the ICU to greater than 95%. They really couldn't tell which patients were actually directly managed by an intensivist in that hospital, and so this wide range in the middle ground really leaves you wondering about whom they were studying. In addition, when you look at the data, they were missing data on perhaps as many as 25% of their patients. They were also missing data on important measures of severity of illness, such as, say, in this case, they were missing data on mechanical ventilation. So it becomes very hard to actually look at this model and understand what they've done and understand how one might actually conclude that intensivists are associated with worse outcomes. Again, association doesn't prove cause and effect, it only hints at it, despite the fact that these authors are missing so much data. And so I think we need, as intensivists ourselves, to look at the entirety of the literature, and this is what's presented in an editorial by Angus and Rubenfeld that accompanies the manuscript, which points out that every other analysis that has looked at staffing demonstrates that more intensivist management of critically ill patients improves outcomes. In addition, there are lots of biological reasons to believe that, and when you look at the data set that Levy and colleagues present, it's missing so much information, and there's so much potential for what's called residual confounding that you can't actually come to a conclusion about what it shows. So I think, again, as intensivists and those who practice in ICUs, we need to be cautious of this article because people might misinterpret it or conclude that the data are stronger than what was shown. The second article I want to do actually shifts gears a little, and now it's from the American Journal of Respiratory and Critical Care Medicine in the June 15th issue, and this moves from outside the ICU to dealing with interstitial lung disease. In this article, Bill Travis and his colleagues in a multidisciplinary group of radiologists, pulmonologists, and pathologists tried to really get to this new disease syndrome called NSIP, or Nonspecific Interstitial Pneumonia. In the 2002 ATS-ERS position statement on interstitial lung disease, NSIP, or idiopathic NSIP, was broken out as its own syndrome. The goal here was to differentiate this from idiopathic pulmonary fibrosis, and as you recall, IPF now histologically is represented by usual interstitial pneumonia on a lung biopsy. There were always a group of patients who had, quote, IPF who seemed to do better than others, and perhaps these people had a different pathology. Now in this article, these authors tried to actually get an expert consensus on what makes NSIP NSIP. And what they did was they reviewed a number of cases that each author contributed, came up with a cohort of nearly 200 patients who might likely have NSIP based on complete data, had this reviewed by, again, a multidisciplinary group, and what they found was that in about half of those patients, or rather 67 of those patients, they felt strongly that it was clear that these patients had a different syndrome. And this NSIP syndrome was defined by a different pathology. There was not fibroblast foci. There was clearly a more uniform pattern of lung injury, may or may not have a cellular component to it. Radiologically, there was peripheral disease and traction bronchiectasis on the CAT scans, on the high-res images, of course, but no evidence of fibrosis or subpleural honeycombing. And then, most importantly, these patients tended to be epidemiologically different. They tended to be more likely female, they tended to be younger, and of course they had restrictive physiology on their PFTs, but the survival rate here over time was actually quite good. And so it's important to realize that we do in fact seem to have a new unique syndrome called NSIP, and it's different from UIP and IPF, and the clinician needs to break that out because it has a different prognosis. There seem to be two variants, as these authors point out, of NSIP, a cellular variant and a fibrosing variant, and we may have different medications for these diseases because there's some suggestion that the cellular form of NSIP may respond differentially and more favorably to anti-inflammatory agents, although at this point that's all essentially conjecture and based on expert opinion and small case series. I think the key issue for the practicing pulmonologist is that they have a younger patient who doesn't fit the classic profile of UIP, but who has an interstitial lung disease pattern. NSIP belongs in the differential. Seeking it out is important, and making sure you have a good pathologist and radiologist who can work with you is important because it allows you to offer a different diagnosis that might actually have a different prognosis. And in the end, we're all about giving the patients the best information, and so understanding that there's a new syndrome out there becomes important. With that, let me stop. This is Andy Shore from Washington, D.C. signing off. Thanks so much.